Well, welcome everyone. My name is Claire Sullivan, and I want to thank you for joining us today. This is our first engagement lounge for the CPEN organization. And CPEN, for many of you, you know, Cancer Patient Education Network, we're made up of a lot of different disciplines. And we're here today and want to thank you for your hard work and for your commitment to patient education in the cancer world. So I think today's topic really falls nicely into our goal as CPEN members and board members here today. I think in our ways of collaborating, in our ways of working together, we really can deliver effective and very evidence-based cancer patient education. And today there's a sense of urgency around our work to be able to take care of cancer patients in new modalities, and new material, new education topics, in a format that we're not used to, where there's little evidence and maybe not as much science behind some of the work that we're doing today. And I know that many of these board members that we have as panelists today, I have personally reached out to in the last 45 days or so. So I think it's important that all of you have an opportunity to reach out to experts that are here as panelists, but are probably also in the audience, as I see a few people that have joined as well. So I'd like to take a few minutes just to introduce each of you panelists, and then we can start. We have some general ideas about questions, and then we'll really hope that the chat will open up and people are eager to share and ask. So I'd like to start with Faith. Faith Addis is our at-large member for CPEN, but she's also a patient education facilitator at Roswell Park in Buffalo, New York. Thank you, Faith, for joining. Just need to raise our hand. Everyone see Faith? Next member is our secretary at CPEN, and her name is Sarah Christensen. Many of you know her. She's from MD Anderson, and she's the director of patient education there at MD Anderson. Next, we have Renee Siegel. She is an at-large member with CPEN, but she is also a program manager at Dana-Farber Cancer Institute, and she has a unique role where she's the program manager of Patient and Family Advisory Council and Special Projects. So Renee, thank you for bringing your perspective today. And then we have Janet Papadakis. She is our current chair of CPEN. And Janet is also a co-director of the Cancer Health Literacy Research Center at Princess Margaret in Toronto, Canada. And she also has a sister joining us. Her name is Tina Papadakis. She is our Canadian liaison. So she connects with us and the board and our membership about events and priorities that the Canadian members are discussing and prioritizing. And she's also a co-director of Cancer Self-Management Research Center at Princess Margaret in Toronto, Canada. So we thank Tina for being with us today. Many of our panelists have, in preparation for today, created some resources. And we would like to just make you aware that these resources that they might talk about are already available or will be available on our CPEN website. And Allison may give us more direction about that later at the end. So that's our panelists. And again, thank you if you're just joining us to our first CPEN Cancer Engagement Lounge. My name is Claire Sullivan. I am your chair-elect, and that means I'm sort of in training to be the next chair, working with Janet and Mariella who are here today. I'm also the program manager for patient education at Dana-Farber. So again, thank you for coming today, and we'd like to start with sort of a general question, just to sort of get our panelists warmed up. And one of our questions is, what have been some of the current challenges that you've experienced with patient education in terms of the COVID-19 pandemic? I'd like to start with Faith, if I could. Hello, Faith. Faith might be having some issues with her connection. Let's move on to Sarah.
Hey everyone, great to be here and great to see all of your names as well. Some of the issues that I'm sure you're facing as well is how quickly the need for content has been identified, and then how quickly it changes. And so, we've very quickly pulled together what is COVID, how do you get tested, how do you self-quarantine, how do you do video visits, etc. And then about 2 or 3 days later, after we've implemented that, someone will say, well, now we need to add this section, or we need to change the phrasing to help communicate a little bit better. So for me, really the struggle is the pace of change.
That's very interesting, Sarah. I think we can all relate to that. Renee?
Hi, everyone. Thanks for joining us today. So I would just reiterate that everything has been moving so quickly. So having a good understanding of what the needs are for not only patient education, but also communication needs for patients and families right now. Logistically, it's really challenging. Most of us are not physically at the organization that we're working at. So having an understanding of what is currently going on, the landscape, being able to get in touch with people that we need to create communication and patient education materials is also challenging, just because of the different priorities that we're all facing. So I would reiterate that everything is changing rapidly, but also being physically separate from our organizations, I think, creates a unique challenge as well.
Mm-hmm. Renee, that's really a really good point. I think it being separated and trying to work from home remotely is another challenge. Janet?
Yeah, I definitely share Sarah and Renee's challenges. Those have certainly affected us as well, and probably everybody on this call. I think another challenge that I spoke with a number of our patient educators in Canada this morning, and a lot of us are struggling with having to very quickly move or mobilize all of our education materials and assets into a format that healthcare professionals can access easily, so they can provide it to patients the way they normally would with print resources in clinic. But now they can't give people print resources. Most of the visits are remote. And even those that are in person, the print resources, probably many of you who had the same experience, have been removed from the resource centers. So all of a sudden you need to find a way to get the information into the hands of the providers to give them to patients appropriately based on what the needs are. In some type of streamlined fashion. I think that has been a big challenge for us. And then just to tack on to that challenge to make it even more of a challenge, we've also had to figure out how best to communicate any new methods or new mechanisms that we're able to quickly put together to actually share that information with frontline staff who are providing care.
Great. Dan, you bring up a very interesting point about the different modalities that are sort of facing us, and we can probably have another whole discussion just on that. I think that's interesting. Tina?
Claire, can you hear me?
Sorry, I was, oh, Faith's there now. I was muted.
Yeah,
Yes.
I was muted. I apologize. I just want, I had two sort of concrete things here that popped up for us. One was the closing of our print shop, so that became difficult or challenging to keep the clinical staff supplied with materials. And the other one was we had just launched a in-person chemo education that the pharmacists were doing with patients, and just weeks before, and that had to switch over to a virtual and telephone thing. So we had to set up new server space and just a lot of IT work and getting all of our materials available through that mechanism. So I think one of the biggest challenges is knowing you have this reservoir and trying to find new ways to get it out.
Wow, Faith, that's very interesting. Is that both for infusion and oral chemotherapy teaching?
Well, the project was initially just infusion, but the workaround solution is being done for the orals as well.
Great. I hope you're measuring outcomes.
At some point.
Great. I think that'll be interesting to hear about that at the next conference.
Yeah, well, we know that what happened was all the clinical pharmacists were working from home, and since they could not get the regimen material we wrote to the patient, the call, instead of taking 30 or 40 minutes to do a teach, it was taking them 2 hours each because people were trying to take notes as they spoke. So we know that outcome right away, is it cut it back in half.
Huh? Interesting. Good finding. All right, thanks, Faith. How about Tina?
Thanks, Claire. I would echo a lot of what you're all saying, and if I were to add something new, we also have scope for patient education skills training for health professionals. And so we've had a lot of requests to advise on approaches for staff, including things like developing scripts for screeners who are frontline with the patients and their families trying to come into the center and trying to mitigate some of the issues that have come up with angry family members or frustrated family members who have been told they're not allowed to come in. So the provider training side has been interesting. Even things like, because our team has so much experience with digital development, being asked to do things that would normally be out of scope, like developing donning and doffing simulations and modules to help healthcare providers learn how to properly protect themselves, and also to respond to protected code blues. So we've really been, due to a lot of our tools and technologies, asked to do whatever needs to be done above and beyond patient education. And that would, I think on the patient education side, it would also include that cancer classes and Cancer Answers online repositories that we have, their access has increased, but the demand to suddenly create rapid resources in order to have all of the classes that are taught in person available online has been a big push. So we went from having 30 classes to 45 and growing every week with an average of 2 or 3 new classes coming live each week. So we've really changed our management structure. So we've gone from running a lot of in-person programs in addition to digital to really taking our workforce and really building on the fact that they're at home and they have this massive opportunity to build digital resources without interruption. So that's been a really nice outcome, I guess, of a very difficult situation.
Yeah, so it'd be interesting to see how your outcomes arrive after that transition and what your findings are. It'd be interesting to hear, what the patients thought about that. I suppose there are some that are really meant to be in person, while others, maybe is a nice transition. Be interesting to hear a little bit more about that as well. Great. I'm gonna just double check. I'm so interested in everyone's answers. Okay. I don't see anything quite coming in yet, so I'm going to ask another question as it relates to patient education. One of the things I've been most interested in talking with my peers has been about talking a little bit more about maybe perhaps the process that you had used for creating materials and the urgency of how the materials needed to be created. What were some of the important things? Like, I know for myself, I had certain steps that we follow when we create new materials. And when I'm rushed or urged to sort of push things further, you don't want to cut corners on what's the most important thing, but you need to push this out at a very fast rate. So how did you prioritize your processes? I know this wasn't a question on our list, but it's one of my questions. So since I'm the moderator, I'm going to ask it. When you're creating things, what do you hold most valuable in terms of the processes that you utilize when you're creating? Faith, I'm gonna come back to you and start.
The process of creating, I would say the clinician's initial input as, you know, a good needs assessment, you know, the purpose of the document or video or whatever it is we're creating, and the timeline. Really, you know, is this, sometimes they ask you for things and the patient is there. You know, they want it right this minute, and other times it's for, you know, a conference or whatever. So that, and then doing the research behind it, you know, fact checking what's there, if it's not for the way that they run their own clinic, but for the, you know, the evidence-based background, and making sure it's valid.
Okay, great. Renee?
Yeah, I think for me, so within my role, I'm not creating patient education materials. I work very closely with Claire and others at Dana-Farber. My focus is always understanding patient and family needs. So through my work with the patient and family advisory councils, as well as other patient and family networks, I think what's been absolutely critical in this time, as it always is understanding the priorities and needs of patients. So working closely with our patient and family advisory council members and determining what patient education needs are coming up based off of this time and the urgency of this time, and working closely with the necessary staff people to make sure that that perspective and materials are incorporated to address those needs. So for me, I think it's really just partnering closely with our patients and understanding what their needs are.
Great. And I think that's really important. And that's really one of the steps. I couldn't let go of that part of my process. I really felt, I mean, I could push the material out without the feedback of the patients beforehand, but I never did. I sort of kept my foot on the gas there with that, which I think is important.
Yeah, and I guess the one thing that I would just add with that is we've been able to sustain our PFACs through remote participation. So in some ways, it's actually been easier to address the urgency because they're readily available, whether it's through email or over the phone or Zoom meetings. So they're providing feedback on all of the materials that are going out currently, which has been really great to have.
So that's a really a good reason to be working electronically is access to that committee. Good. Janet?
Well, I'm happy that our group was able to develop, and probably most of you did the same, streamline an approach where we would have rapid approval from appropriate subject matter experts as well as our IPAC, infection prevention and control experts, who were aligned with our Ministry of Health to ensure that the information we were sharing that was related to COVID was consistent with the most up-to-date evidence. So another group looked after that. Subject matter experts looked after the subject content. And then we did have a nice process for reaching out to a remote PFAC as well to get patient and family feedback. But on our end, I think the part that has been, to me, the most amazing is how quickly we've been able to expedite plain language review of these very complicated documents and still get them turned around in 3 days on average. Some of these are 5 pages and some of them are 16. We had a Whopper come in recently. And even though it came in late at night, the team was committed to getting it turned around really fast. And it just seems that there's been a great spirit of collegiality, and people are willing to put in the time and expedite these projects. And that's something I've really noticed. And I think the plain language element of all of this, if we think about all of the mixed messages and confusing communication that's come out from so many different data sources, what patients really need is a really clear, plain language direction on what they need to know on the information that's specific to them. And I have been really pleased with how quickly the group has been able to come together to prioritize clear communication.
Yeah, I think that's a really important point. I've noticed that myself. Good. And Tina, how about you?
I think it's very much to a lot of the points that you've all been saying. We're not letting go of the patient education standards and quality markers. You know, we're still talking to patients. We're still adhering to plain language. It's more about using our experience, our social capital, and our processes to get the work done quickly and rapidly, while not stepping away from the universal precautions approach. And I think that's really important because it's a scary time. It's an overwhelming time for a lot of patients. And the goals of clear communication are probably even more important right now than they normally are. So it's really amazing to listen to you and hear that no one is dropping the standard, but merely working harder to adhere to the standard. So it's pretty amazing.
Mm-hmm. Mm-hmm. Good. Yeah, I think that's great. I think I like the way you summarized that. That's great.
Claire, I'm going to jump in as well. And so,
yes, Sarah, sorry.
No problem. Just again, to support all the things that you've said, and having really engaged clinical experts has been tremendous, because you're doing the 1-2 day turnaround in order to meet the needs of program implementation. But for us, the one thing that I'd also like to share is I too have so appreciated the ability to do health literacy review. And we've worked very closely with our internal communications team. So the patient education documents, the messaging to clinical staff, and then the scripting that our phone triage people will have, it's verbatim. We are using the exact same languages in all places. So no matter who the patient hears it from, they'll hear the exact same words, and just trying to, as Janet mentioned, alleviate that any differences in messaging. And I think that's been a really huge boon for us.
Was that something new, Sarah, that you started during the pandemic, or did you have that link to that call center?
So we had the link, we had the coordination, but to be part of the scripting, so, you know, like video visits, they needed to know how to help patients log into their MyChart account and start their video visit. And so they needed the patient education instructions from which they then did their scripting. And so it's enhanced already existing, but actually I think everyone's learned to see the dependencies that we have with one another. And it stretched us out of our education role in a little bit. So much of what we're creating right now is instructions. But the great part is that clinicians like our education platform. So it's like we'll be happy to create the instructions, put them on our education platform, because they know how to access it and get it to patients easily through that existing platform. So it's really kind of emphasized and highlighted what education can do, even if the content's not, you know, traditionally education.
Excellent, excellent point. Sorry about that, Sarah, though, because I didn't take you in the right order. That's great. We do have a couple of questions that sort of build on this this topic. that I want to share. First one comes from Megan Rossler. She's from Mayo Clinic in Rochester. And she has also moved her classes from Mayo Clinic to Mayo Clinic Connect. So they quickly recorded a lot of their classes that typically are offered in their center so that patients can access them. And she included the link for everyone to have. Megan, did you want to have another comment? You have more comments on that? I think we'd like to hear more about that. Megan, are you there? Let's see.
She said she can't get her audio to work.
Oh boy, okay. All right, well, maybe we'll come back to her. And then there was, Janet actually had a question for Faith in terms of her fact checking. Do you want to comment on that question, Janet, in a little bit more detail?
Sure. So I know Faith's at Roswell, Faith's program actually looks at the clinical content too. And I know, Faith, you're in the position, you're a nurse by clinical background, and I don't know how many of the other patient educators on the call have a program with expertise in-house. And so we always rely on subject matter expertise from our collaborators or from the clinicians we work with. And I've always found it really interesting that Faith is responsible for fact checking. And I just thought other people would be interested in hearing more about that.
Yeah, I don't approach it that, you know, we investigate everything that we know what they state. I assume they are the subject matter experts. Unfortunately, sometimes there's multiple subject matter experts within the same department that don't hold the same opinion. So then that becomes a matter of, you know, kicking it up to, you know, the medical executive board or someone else, where it becomes, okay, now we need a hospital policy because I need to know what to tell people, and it needs to be a consistent message. And the other thing is the drug regimens that I create come from the pharmacists, and they're very busy, and you know, they copy and paste as they move from one regimen to another, and they can sometimes bring over, you know, maybe a side effect that I don't normally consider to go with that particular chemo or immunotherapy. So that sends me off into research as well.
Mm-hmm.
That's great. Do any of the other panelists or anyone else on the call have a similar program in place? To me, the clinicians are very lucky to have that available through you, Faith.
So feel free to tell them that.
I think from a Dana-Farber perspective, we have agreed with the pharmacists in terms of when you say side effects from a medication. We have a certain guideline in which we include a certain certain percentage of the side effect, so that we're all sort of talking the same language when we review documents, that we have sort of agreed upon what to include ahead of time. I don't know if that is clear or helps people understand, but I think the more guidelines and processes you have, the easier and more efficient I think different disciplines can work with you. We do have some questions here coming in. Poor Megan from Mayo is not able to get her audio and video to work, but she has sent us the link, so we'll share that with everyone. Gila is asking a question. Gila wants to know, does anyone offer virtual patient education classes in real time? if yes, what platform do you use? Any of the panelists want to comment on that? Faith?
We currently do not. We are just setting up, and where we was talking about the virtual visits with the pharmacist. Part of that chemo education process was a visit to our resource center, where the staff would orient them to support services and the non-medical aspects. And we are now, the resource center is closed. It's a respite center for staff now. And we are the ones calling the patients to set up the virtual visit with the pharmacist and using that as an opportunity to do the orientation, do the chemo orientation. So it's not a class, it's an individual thing. Session.
Okay. Sarah?
So Gila and I are watching closely what's happening at Anderson. Hi, Gila. Our social work team is setting up real-time support groups. And so we're just kind of trying to see how they're doing that. Our clinical dietitians are looking at doing a nutrition class in real time. And the issue that we're facing is really what's the right platform, and also how much of it is HIPAA protected, what's the confidentiality, there's so many compliance issues, because what we'd like to offer is not a clinical consult. We don't want to document it in the record, but a lot of the platforms that are being set up within our institution have that in mind.
Mm-hmm. Mm-hmm. And so you're curious to see what other centers are might be using. Great, great. Renee?
Yeah, at Dana-Farber, we've moved a lot of the programs and workshops virtually. So from my understanding, I believe we're using Zoom for most of those classes. In the Resource Center, actually, Maritza Nassif is on this call right now, who manages that work. We've moved our spirituality and cancer workshop, managing finances, all to a virtual platform. As well as the Zachem Center for Integrative Therapies has been offering some of the integrative services through Zoom as well. And I believe our social work department is starting to offer support groups remotely also. So we've fortunately been able to move a lot over to Zoom.
Thanks, Renee. Janet?
I'll defer to Tina to share what's going on at Princess Margaret. She's been leading this piece of work.
Thanks, Jen.
Okay.
We had heard about some issues with Zoom with hackers. And so there's a lot of concern around our organizations. Our IT department is really recommending not to use it. But we do have something that we're able to offer live courses with, which you probably all have in-house anyway. How many people use Microsoft Teams? So if you have Microsoft 360, we don't all have license to the live events option in it, but IT groups will have the option. And so instead of setting up a Teams meeting, you have a person set up a live event. And that way there's a lot more safeties on the patient side. They're unable to share their camera. They're able to log in with aliases, and it can all be recorded. So it has a lot of benefits, but without a lot of the risks that some of the other platforms come with. So Microsoft Teams has been, live events specifically, is a really nice option if anyone's investigating choices. Now, it's not secure, so it's not for clinical teaching. It would be for basic general patient education classes where one-on-one advice isn't being provided, because it's not secure enough for that. But it is considered quite a secure mode for things like Chemo 101 or other classes that run on a regular basis.
I'll support the statement that we know we can't use Zoom to engage with patients. And so looking at Skype or WebEx, but thank you for the tip about Teams.
I'm just going to type in the comments the full name of the specific aspect of Microsoft Teams so everybody has it.
That's great. That's great. I know I dialed into some of our integrative events that were being held externally, and I was a little nervous because I was wondering if they were going to share our screens and others would see me, but they didn't. And so you only saw the person that was actually giving the talk or doing the cooking, because I did a nutrition and then I did one with cancer and music therapy. And both were really interesting. But I wish that I think before I registered that I had a little bit more information about the safety of the interaction. I think that's sort of something that's important to highlight when you do the classes. Any other panelists have a comment about that? I think I got everyone. Okay.
I could tell you about one particular safety issue that didn't work for any of the methods that were in place, which was for the Christmas class. A lot of the education in that class is very specific and almost given to patients as a prescription, and so we couldn't have it open and live. It has to be recommendation only. And so for that class, we were able to just build it in a little web sandbox with a hidden link. So it's kind of a workaround, and it's not like a gold standard moving forward, but it's a really lovely way of solving a problem very quickly. So we were able to create an entire web page with all the education on it, except it's a closed page and nobody else can find it except for patients who have been approved to do the trismus free and rehab.
That's an interesting strategy.
I would just add, I know Dana-Farber is taking extra security with Zoom by using the waiting room and a password for people to enter the meeting. So I think that helps with the privacy. And as Claire mentioned, we're having it so that the facilitator is the only one that can be seen on the screen.
Bethany is in the audience, Bethany Sanborn. Hi, Bethany. She's created a variety of different versions of patient instructions for Zoom and continued to identify other issues. We also would like brief instructional videos. Does anyone have such resources that they would be willing to share? Bethany, do you want to comment a little bit more on that so the panelists might know a little bit more detail?
Sure, can you hear me?
Yes.
So we have been exploring Zoom for visits if you are in the hospital with someone, with a loved one who is not in the hospital, since you can't have visitors. So that's not necessarily patients with COVID, but just whatever you're in the hospital for our oncology patients. And so trying to give patients some instructions, even if they have their own devices, just on how to use Zoom with a family member. And we think we've tested it, and then we figure out that someone doesn't, has an iPhone and someone has a Android device and our instructions don't work. And it's like version after version after version. Just wondering if anyone's figured it out yet.
So at Dana-Farber, we are creating a Zoom instruction guide for patients. I'm not entirely sure if it's public, but I can definitely explore that and see if that would be available to be shared. We've actually, for our Spanish-speaking population, one of our patient navigators has created a tutorial video in Spanish for how to use Zoom. And we've actually worked on some other videos to communicate different instructions or COVID information in different languages. So that's something that we're working on as well, which I think would be public, but again, that would be in Spanish. So I can certainly see if that's public and able to be shared, but it is a resource that we are working on.
Great. Anyone else on the panel? Faith?
We're not using Zoom with patients. We use WebEx, and it's, you know, we send them an a link, and it's and that's their access. So it is private, and it does go right into the medical record. I'm sorry, Claire, you're cutting out. What?
Faith, it goes right into the medical record?
Yes, it gets logged in to the medical record. So the WebEx, that's when I mentioned the calls we were for to the people setting up their virtual visits. They are instructed how to download WebEx, and you know, we walk them through that process so that when we send them the email with the link in it, all they have to do is click the link and it will launch the virtual visit.
Right, so I guess we're hearing there's sort of difference. We're talking about two different types of videos for patients. One is when it's part of clinical care virtual visits, as well as clinical patient education. But then there's the other side of that. Maybe there's three different things. And then there's the middle ground, which is group education that isn't going to be specific about anyone's clinical condition. It's really education, pretty general. And then there's the third, which Renee was talking about, and Megan, I think it's Megan, who was talking about how to facilitate connectivity of patients. So if I were taking a friend to Princess Margaret, and I would normally like to be there to take notes for them and be an extra set of ears, but I'm not allowed to go in the hospital with them. Maybe I'm not technically savvy enough to know how to use FaceTime or Zoom or any of these. And so I think there's also that description of how to help patients to sort of virtually accompany their loved ones to appointments, which it sounds like Renee has a video in Spanish, which would be great to see. And it sounds like, I believe it was Megan who has, or Bethany, who's working on various print descriptions to help people access Zoom or FaceTime or any of these other things for their personal use, which is quite different. All of which very interesting to hear.
The if it's a matter of a caregiver wanting to be part of the clinical discussion, that's all covered in the WebEx instructions to include those extra people. But when it comes to just how do you use Zoom, we have not created any materials for that.
I wonder if anyone else on the call has created anything to help patients figure out how to activate Zoom or FaceTime or whatever when they've been told they're not able to accompany a loved one to an appointment. Kind of opening up beyond the panel in case anyone has anything out there that we could all leverage.
Janet, so not quite the exact same scenario, but when our patients do video visits, they actually log into their MyChart account, the Epic patient portal, and then they launch Zoom through the portal so it's secure. And the next phase now is allowing patients to invite other family members from around the nation to join that call, so they're part of the video virtual visit as well. But we're working on that. We don't have that completed. And it's very specific to our setup of MyChart.
Go ahead, Renee.
Sorry, this doesn't necessarily answer the question or provide something that can be shared, but just something for others to consider. Our volunteer services department is considering training volunteers to potentially provide support to patients to help them sign up for Zoom and access their Zoom accounts. So we are using a third-party vendor within the broader healthcare system where patients can call almost like an IT support desk for help for signing up with Zoom. But by utilizing our volunteers, we'd be able to provide more of that personal touch our volunteers are trained in customer service and could really provide that compassionate connection, as well as the guidance around utilizing Zoom. So we're figuring out the process with that right now, and hopefully we'll go live with a program soon.
It's great, Renee. Anyone else? Janet or Tina?
I don't have much to add, although I
Okay.
really like the idea of providing some instructions to facilitate that face-to-face connection. And I love the idea that Sarah shared of figuring out a way that patients could invite other family members to remote into their appointments. That's incredible.
Yeah, that is really good. We at Dana-Farber have the similar process, Sarah, where patients have to enter into their MyChart. We call it Patient Gateway, and there's a link there for them to enter to do both groups with their support as well as their physician. There are some answers coming across the chat room. Erica Schoenman is from Dana-Farber, just wants people to know that we have Zoom instructions, but they don't differentiate between the different types of phones. But it does do a great job in terms of step-by-step with pictures. I think that they're looking to share that. People are interested in the Spanish tutorial, Renee, to share that. And I think it might be Laura Carr, I'm not sure, wants to know a little bit more from Janet and Tina about e-learning and what the numbers are of people using these resources in terms of the uptake that you've experienced. If you could talk a little bit more about that, I think there's an interest.
I haven't looked at the usage numbers for Cancer Answers. Janet might be able to speak to that. But for the e-learning, in the last 3 weeks, since this crisis really started to take off and changes really were being felt at the Cancer Center in a more pronounced way, there's been over 100 new users to the system. So 100 is good. It's not shocking to me. Like, I kind of would have liked it to be 1,000. But the system has been live since September, and there were 700 people in it since September. So if you look at a percentage increase, actually 100 is quite a significant change. So of the people who know about it and are using it, it's getting good uptake. But I think we need to do way better with our communication and outreach to the public to let them know this is available. I don't think patients are really getting, I don't think people are really hearing about this unless there's a really invested health professional who's telling them specifically. So we are in touch with our communications department just this afternoon, actually, asking about other channels to reach the public. Everything is focused on COVID, but not always on really important patient education. And so trying to add to the discourse the importance of sharing other information and other resources that may not specifically be COVID related, but are really important during COVID, I think is the next step for us.
Mm-hmm.
Janet, did you want to add anything in there? I guess that's where your digital education prescription would be useful to talk about.
Yeah, I can tell everybody about it briefly, but I'm not sure how, well, maybe other centers have something relevant. We were able to deploy really quickly something that we called the digital education prescription. And it was basically, it is a way that staff can access very specific clinical inventories of patient education materials and select from a list and email that content directly to patients. And all of the classes on Princess Margaret Cancer Classes online are indexed in there. So for example, if you were a gynae oncologist and you had a new patient, let's say a breast surgeon, you had a new patient coming in and you wanted to send them the new patient surgical binder, a prepare for your surgery, and maybe a reconstruction pamphlet, you would just open up the digital prescription, choose from your list of clinics and disease sites. So you'd pick breast, and it would index all of the patient education materials that the staff typically use in clinic. All of it is there, both digital and print formats. Of course, it's all digital because it's being emailed. And you can just select those things very easily, enter the patient's email address, and off it goes. It's extremely smooth and extremely easy. We are working to get it connected to our EPR, to our patient record. It isn't right now, so you have to actually get the patient's email address from the patient. But people are using it on their digital, on their virtual visits to send information. It's a good way to promote these resources to staff and to give them a really easy way to send that information directly to patients. And it wasn't, it's not a super high-tech solution, but it's extremely effective. So we've been seeing really good uptake. We just launched it on Thursday last week, and already we have hundreds of users. So very exciting.
Jana, what platform do you have that built on?
SharePoint right now,
Okay.
which is what our website's built in. So, and we have a team member who is a SharePoint developer. So it was something we could do ourselves pretty quickly. So that was very exciting. We looked into whether or not there was any way we could share it across our province, which would be similar to your state. And there isn't yet, but we're working on a solution.
That's
I'm curious.
fabulous.
Can I pose a
You've got
question?
Laura, I think, on chat saying, wow.
Okay.
Go right ahead.
I wanted to ask everybody on the call if anyone has a video or something, any kind of a resource that they give to patients telling them about the opportunities with iPads or different tablets for virtual visits or for virtual caregivers to attend. I'm just wondering if anyone has anything that would be something that we could share on the Princess Margaret website to say, you know, to tell patients this is something you can do, because a lot of people probably don't think about it. And unless clinicians are actively telling people about the option to bring someone with them on their device, they may not even think of it. So I just wondered, has anyone got anything basic that could be shared or used, leveraged?
Anybody on the panel?
Well, this is Faith. We just did something similar, but you know, it was all kind of done. We're working on a big data project which will solve a lot of issues, but we had to kind of hunt so quickly because of the pandemic that we do that, but we don't have anything telling people how to access it. It's all, you know, kind of off the cuff on the clinician's part. And the scheduler, when they call to make the appointment, they say, you know, do you want the virtual? And they set it up. And then we've set up the mechanism for anyone to be able to send that material to the patient without them having to be in the portal. They can have it used to have to be in the portal to have a virtual visit, but because of the people have limited access, you don't have to do that anymore. Now you can do it outside of the patient portal. But I would be interested in that too, because we don't have anything to explain it because we developed it so quickly on such a, you know, an emergent basis.
So I'd just like to add, we really focused on educating our providers and our front desk staff about reminding patients that since it's a zero visitor policy, you know, feel free to bring your device so you can call in your loved one or FaceTime them. So rather than educating the patients about that opportunity, we've made it a key talking point for our staff.
Yeah, that's been the same for us at Dana-Farber. So the information that we provide to patients that communicates the no visitor policy, we encourage patients to FaceTime or call in a family member that might want to join their appointment. Our website team and communications has also done an incredible job creating a web page specifically for COVID. I can send the link out to everyone. And I'm actually looking at it right now, and there's a section specifically on telehealth visits at Dana-Farber providing information. So I would certainly recommend working with your communications team or whoever manages the website, and any avenues for communicating to patients. That's a great way to get this information out.
We were able to create a COVID-19 and cancer recommended resource. And Gila, I'm wondering if you'd like to unmute and just share a little bit about that. And you can find it if you Google MD Anderson recommended resources. It's also linked on the CPEN webpage.
Thank you, Sarah, for bringing that up. So I guess we share the recommended resources online from the Learning Center. Quite, you know, a lot in the past, but the latest addition, as Sarah mentioned, is a COVID-19, coronavirus, COVID-19 and cancer recommended resources online. So it's, you know, very helpful to patients and families, and of course us, everyone who's involved in helping patients finding information and resources. So I believe Sarah sent that link to Allison, and Allison's going to share that with everyone. Please feel free to promote it, share it, and make suggestions if you have other resources that you think. Send it to us. And of course, Valerie is our staff who was, you know, behind that, and just, you know, quick turnaround to create that resource was awesome. And another thing from the Learning Center part, I don't know if others have, because we're virtual and we are still available. Interestingly to know that we have an email address that we were hoping is going to be utilized more, but the actual usage of that service has gone down. But the uptake on the recommended resources online, it's interesting. So there has, I don't have the exact number and data, but the first 3 weeks after we started working from home and going virtual, we saw an increase, and especially advanced care planning resource amazingly has been getting more attention. But overall, our online resources, recommended resources online, has been very useful. Thank you.
Claire, you're on
Sarah, I
mute.
think you're muted. Oh.
I just want to make mention of the time to everyone. It's just about 3 o'clock Eastern time. And so this is sort of the end of our first engagement lunch. I think that we could go on for hours here. I feel getting going with sharing resources and talking about what has been some of our opportunities and what have been some of our challenges. I think I'd like to thank everyone, and for everyone that's participated. Please send us your feedback. We'd love to hear if you thought this was effective, and be safe out there, okay? We'll talk to you soon. Bye now.